And I really like pro-con debates because I think it's a nice way of showing the same studies under two very different perspectives. Especially I like pro-con debates when I'm sitting there, not when I'm here. But anyway, so my personal, disclosures have nothing really to do with this talk. My more personal disclosure is that I come from Monza in Italy, which is not far from Milan, and it's probably known because the Formula One race is run. There is the very nice villa that was the summer house of the king. But I'm saying this because in Monza, thanks to our former boss Antonio Pesenti, we have also been running a program for ECMO for many, many years, even in what I would call the middle age of ECMO, where ECMO basically disappeared from the scene in the 90s, 2000s. Still, we were doing ECMO. So as a student and resident, I really grew up with ECMO on my side. So today, speaking against ECMO is really biting the hands that feed me. But anyway, I think there are some important points to remember. And so I think that ECMO is not always an option, and I would split my talk into, again, going back to some of the studies that have been shown, is not an option for all patients, and it's not an option for all centers. I think you already heard this, but I would like to go back to some points. So why is ECMO not an option for all patients? ECMO, first, what are the indications for ECMO? So before saying who does not get ECMO, I think we should say who gets ECMO. And I think we have two main indications for time being. Again, I'm talking about ARDS, so forget about VA ECMO. So ARDS, I think we have two main options, indications. One is quite, I would say, coded, which is rescue of refractory hypoxemia. And as you've heard, the other one, which is even more blurry in the literature, is perhaps an ultra-protective lung strategy. This is an example of some criteria that have been advocated for the use of ECMO to rescue severe ARDS. So the indications are here, and we have well, the inclusion criteria for these authors, and you can pick other studies, but to give you an idea, is a PF ratio lower than 80 with a PEEP greater than 5, okay, with ARDS, or refractory acidosis, respiratory acidosis. Then we have a set of absolute exclusion criteria, which is, for example, a long mechanical ventilation, a known disaster in the brain, and I think we would all agree that this is not the patients we are discussing about. I mean, if a patient is brain dead, of course, there's little discussion on this. But I know that every day, and I know this really from my daily clinical practice, from working in an ICU that does ECMO, is that we have some relative exclusion criteria. We just heard of 2 patients with cancer, and again, state of immunocompromise is like a relative exclusion criteria. The age is, you know, now patients are getting older. What's the problem? The problem is that if we look at our patients, we must face the fact that in this cohort of patients that were considered for ECMO, at least one of these relative contraindication was present in the vast majority. So I would say that, well, of course, you can use the argument both ways, but almost every patient has one good reason not to undergo ECMO. And just, I think, saying, well, let's give ECMO to all patients unless they have an absolute exclusion criteria would, you know, incredibly increase the number of ECMO which we perform without being certain of the effectiveness of this treatment. Now, you've seen this study already, so I go very quickly. This is really something that speaks against my side. Very nice study done by the group of No in the UK, showing that ECMO-referred patients for H1N1 had much better outcome than patients not ECMO referred. Now the problem is that, luckily enough, H1N1 had a spread. Of course, we will have to face H1N1 again, but this is not the most common cause of ARDS which we see in our ICUs. Patients are affected by bacteria, by pneumonia, have coexisting disease, are in shock. So I would argue that if we just focus on the specific subsets of patients with H1N1 that besides the very acute phase where patients are killed normally as a self-resolving evolution, then this is a niche in which I think ECMO is extremely powerful, and yes, of course, it should be used. But if we go to the CESAR trial, which was, of course, which is normally considered to be a positive trial in favor of ECMO, does the CESAR trial really show that ECMO per se saves lives? It was already mentioned that more than 25% of patients did not receive ECMO. And of course, intention to treat, so from a statistical point, this analysis is correct, but really 22 patients that were supposed to receive ECMO did not receive it, just because they were brought to a center where they set the ventilator better, did other things, and the patients improved. So this not only is an element that makes us a bit skeptical on the real role of ECMO, but makes me skeptical on the control group. Because those patients in the control group were still treated at the referring center. So, sorry, at the referral center. So, referring center. So, these patients, once moved to another center without ECMO, improved immediately. So perhaps the care they were receiving was not exactly the best one. And of course, it's very, very easy for me to stay here at the podium and criticize other people's works. That's very, very easy. And I think that the CESAR's investigators were great and did an outstanding job, and we know a lot thanks to this work. But I would like to stress the point that even in the context of refractory hypoxemia, what we know about ECMO is not that robust. And indeed, the group of, I'm missing the name, anyway, from Paris, Ellen Combe is running this EOLIA study, which is randomizing patients to receive ECMO or not to receive ECMO after the clear evidence of refractory hypoxemia. And indeed, the fact that such a study is ongoing does not speak per se against ECMO, but I think we should all be cautious about the fact that what we know about ECMO is still just the beginning. So let's look at the clinical case. You have in your ICU a 66-year-old patient with a Legionella pneumonia, PEEP is 10, plateau 36, ventilated. Well, you read the data. Those are there. And let's say he has a PF ratio of 70, okay? 70 of PaO2, 100% FiO2. Would you put this patient on ECMO? Raise your hands. Yes? Perhaps I would. No? Don't know? Okay, abstention is quite large. So, just to give you an idea, there are scores in the literature that allow you to predict the likelihood of such a patient to survive ECMO. And of course, again, anything can be criticized, but before starting a treatment, I think we have to have a rough guess of the chances of a patient to survive the ECMO. And if you compute the preserve score, for example, for this patient, his chance of survival is less than or around 20%. And yes, you might decide to give this patient this option, but I think we have to think carefully before deciding to put such a patient on ECMO. And just to give you an idea, if your preserve score is between 5 and 6, you hit the mortality described, for example, in the lung-safe study for severe ARDS. So if you want to make a difference, for example, and you use preserve score, if you want to make a difference in mortality, a real difference in mortality, then you should have a really low preserve score. And another argument I would like to bring up is the fact that ECMO can be an option, especially in the early phase. So after some days, I think ECMO is less and less and less of an option. So when we receive a phone call from another ICU proposing a patient, one of the first questions is how long has this patient been ventilated for? And yes, you can think about ECMO, but you have to think of that early. If 5, 7, 10 days has passed and nothing is happening, then I think ECMO is probably not an option. I would not say ECMO is never an option, because of course we do ECMO and ECMO saves lives, but it's an option that is less and less appealing. ECMO, of course, has complications. We heard about that. I would just like to recall you that, for example, about 15 to 16% of patients treated with these bullets are ARDS patients, ECMO for ARDS, experience severe neurological complications, so intracerebral bleeding. So now this is getting lower and lower and lower due to the improvement of the techniques. But again, this speaks for experienced centers who know how to manage anticoagulation, who know how to manage CO2. Because if 1 in 10 of your patients, which is even less of this, if 1 in 10 of your patients dies because of cerebral bleeding, then it's very hard that you will be able to make a difference in the figure overall. So you might think that 16% is a relatively low incidence of neurologic complication, but you are working to reduce mortality. So if, as I say, if 1 in 10 patients die of cerebral bleeding, then it's really hard that you will have an impact on mortality overall. And of course, many of these patients also get nosocomial infection. In about 10 days, 50% of your patients will get some nosocomial infections. So going back to our question, what are the current indications for ECMO? Rescue of refractory hypoxemia. How many of you, if you go to the bedside and see the patient has saturation of 80%, would be very concerned? Not concerned at all? Don't care. Okay. Well, it's interesting, this story, because these guys, they are from the group of Palmer, okay? And he's one of the, I would say, charismatic experts on ECMO. He has some clear ideas on how ECMO should be done and should not be done. And of course, he's been one of the users, long-day users of ECMO. So they put ECMO to rescue patients from refractory hypoxemia. And then they do this study. And what's the mean saturation they have during ECMO? 80%. So they do ECMO to rescue refractory hypoxemia, but then during ECMO, patients have 80% saturation. And I'm not saying that if I go to a bedside and I see that saturation is 80%, I start to be very, very concerned, okay? I should have raised my hand. I don't think that it's so easy to accept that hypoxemia does not harm. But it's just to say that even in these patients, a very low saturation for many days did not have any impact on their neurological outcome. So the question is, why using a technique that is supposed to rescue refractory hypoxemia and then keep the patient hypoxemic anyway? And then my last point on this is Latin, frustra fit per plura quod fieri potest per pauciora. It's useless to use more resources to achieve something that you can achieve with less resources. And I was very pleased to see that the LungSafe study was quoted, just to say that if we are concerned of refractory hypoxemia, I have a hard time in understanding this data which we collected with the LungSafe, in which in severe ARDS, PF ratio lower than 100, average PEEP was 10 centimeters of water. And I even had a harder time understanding this graph that shows you that in half of the patient in whom PEEP was, in whom FiO2 was 100%, PEEP was below 10. And again, this is not, and also this shows that we use less and less recruitment maneuvers, and we rarely prone patients. This, you might say, this has nothing to do with ECMO, because of course, ECMO is supposed to be used after this treatment fails. But the point I would like to make is it's important to think of ECMO, but it's very important to think of what has been done before ECMO. What can we do before ECMO? So in this sense, ECMO is not an option. It's not the first option. You have the patient, he's hypoxemic, let's put him on ECMO. I don't think it's the way it should work. I think we should try to increase PEEP, to use recruitment maneuver, to use prone positioning, and then think of ECMO. And this does not seem to be the case. I'm positive if we did a next day on prone positioning, the room would have not been so full. So there's a big momentum on ECMO, and I think it's great, but I think it's important that we do not forget to do things before ECMO. Concerning lung protection, sorry, I am missing a bit of a fantasy. So the scheme is more or less as before. We also have studies ongoing on the ultra-protective ventilation in ARDS. I think the study by Dr. Bain is, as far as I know, the only data we have in the literature on the use of ECMO to protect the lung, to ultra-protect the lung. But again, I would use the same sentence as before to wonder why are we so thinking of extracorporeal CO2 removal once we use a respiratory rate of 22 and a tidal volume of 7.46 ml per kilo. Wouldn't it make more sense to increase respiratory rate and decrease tidal volume, or just accept a higher PaCO2, whereas the mean PaCO2 we have in our patients is 40? And again, you can use this argument both ways around. You can say, we do this, but sometimes still the patient cannot eliminate CO2, pH goes down. Fine. And in these cases, I would not say a word against ECMO. I think there is a role there. The point is, are we sure that all that was to be done has been done? And finally, I would conclude with this also emphasis on the centers, which is the fact that this position paper tells that we are sorry, we should not be doing ECMO in any centers. It's something that requires organization, that requires skills, and that requires a given number of patients to be, always prepared to what can happen. And indeed, this is a, let's say, a observational study that shows that starting from a mortality of, let's say, 1, our reference, without any ECMO, if you are able to drop this mortality significantly only if you perform a given number of ECMO runs per year. So for example, in our center, we are not maybe, we don't have that high number, but we do more than 50, something between, I shall say, 50 and 80 cases per year, depending on the year. And this is why it is so important, and it has been stressed already, the fact that these patients should be centralized. This is the system that was set up in Italy for the H1N1 pandemic, and the idea was that the originating hospital would call the closest ECMO center, and that there was not just the consultancy on ECMO per se, but on the entire patient management. So did you try prone position? Did you do recruitment maneuver? And there is a continuous feedback. And then eventually, if the patient is not, is still refractory, then of course, he or she is transferred normally under ECMO. So in conclusion, ECMO, I think it's important that we always have in mind that ECMO is not a goal per se, and this was beautifully said before too, it's a tool to achieve a goal. I think that we have to be aware that, as in many other things, we have more, I would say, uncertainties than certainties. That we have to make sure that we think of ECMO, we think of that early, and that all supportive strategies have been used, high PEEP, low tidal volume, blah, blah, blah. And please don't think that your center is like a lower league, or you're working in a not so nice place, not so fancy place if ECMO is not done. Perhaps it's just a wise place that it's able to treat the patients and then, for their best, call a referring center for ECMO. So ECMO is a bridge, but a bridge to nowhere is not an option, I shall say. Thank you very much for your attention.
Any comments, Stefan? Before we open up to the floor.
You mean I should give a comment? Okay, well, I mean, I can give some comments. Thank you for this very beautiful talk. And there are a lot of things where I completely agree. And there's one most important point you mentioned, and I also mentioned. I mean, before you not have taken all advantages of conservative therapy, and I mean, optimizing PEEP, optimizing VT, and maybe look for hypercapnia, and stabilizing the patients and putting in prone position. Before you not take all these options, you should not consider ECMO, and I 100% agree with it. But a part of this, then there are patients that may benefit from an ECMO, clearly. And the other thing I also completely agree, and this is more difficult, to focus on the right indication. I don't think that only and I clearly say this, not only H1N1 patients do benefit from ECMO. From my experience in our center, the most of these patients do have severe pneumonia, community-acquired pneumonia. And if the patients do not have severe comorbidities, they have a low mortality, much lower mortality, as reported in the literature. So I would extend this for this patient group. I clearly see clear indications. The other things, the broader indications for patients with comorbidities, this is difficult to decide, and there we have to find the right way.
Yeah, it's more it's not exactly a debate, because I think we are on the same line. So perhaps I was not that clear. I would say that H1N1, it's clearly a situation where where ECMO works very well. But of course, for us also, the vast majority of patients, just because of seasonality, is, as you say, community-acquired pneumonia of different types, or even viral pneumonia sometimes. I guess the most difficult point is to have an idea and balancing the comorbidities. So I think that's the trickiest point, because I've shown you, of course, the score, and this is, I would say, a tool that gives you a rough guess, okay? If your expected mortality could be 80% or could be 30%, which makes a lot of a difference. But of course, as physicians, we just don't like, to make the computation at the bedside. And so it's more of a, I would say, clinical judgment. And I think this is when it's much harder to decide in this gray zone. So, for example, do you use SCORE or you go by?
This is an important point. Well, I mean, we know there are different scores in the community, and you have to take in account these scores are not prospectively proven; they are just retrospectively constructed and give us a little hint. So, well, we look for risk factors and we take this in account. But this score would never be, for me, the decision not to put somebody on ECMO because of the reason it is not prospectively evaluated. So, but it may give you an idea, and then you have to really make an individual decision for the patient.
Yeah, we do the same.
I would like to thank both of you for the wonderful talks, and it's always a little bit frustrating if you do a debate and everybody agrees with everything, so we need an enemy. That's important. No, I just want to bring up the problem or the issue with the companies and the center question, because I know that there are companies out there which are propagating ECMO as feasible for everyone with mortality close to 0. And the companies are even sending out perfusionists with the ECMO and say, okay, don't worry about the technical issue, you can do it. And I probably know what you're saying, but I think it's important in such a course because the aim is not to come here with the idea of ECMO in your mind, going back home and starting ECMO, but I think it's really dangerous, and it's a dangerous pathway that we are going when we think it's only the machine.
And it's easy to answer. This constructions has nothing to do with an ECMO center, nothing. I mean, there's somebody coming, putting on the machine and then saying goodbye. And where's the center? I mean, I just show what do you need for a center. This is clear. I mean, we will give an idea for these structures in this German guideline. Well, you have to have some sort of surgeons who are experienced in vascular surgery. You may have to have cardiac surgery, thoracic surgery. You have to have the ability 24 hours, 364 days a year to go into the CT scan, to do angiography, and to have some procedures like that. This is what we think you have to have. And you have to have experienced doctors who are working on this station for years and having the experience and having reach-out teams taking the patients to the centers. This is what we do understand under center.
Yeah.
I mean, and it's probably the same. I mean,
No, I'm sorry to frustrate Bjorn, but again, we agree. So I wish we would disagree more. But no, I'm not joking, because I mean, then when your patient is infected by Acinetobacter baumannii or he's bleeding to the nose, what are you going to do? Call the perfusionist and say, what shall I do? I mean, as it was said, the point is not the technique. The technique, I would say, is relatively easy, is straightforward. The machines are working fine. It's not like the Kolobov machine. The problem is caring for the patients for many days. I mean, sometimes ECMO runs last 50, 60 days. And sometimes you don't see any improvement at all. But still, you are facing multiple clinical challenges. The patient becomes has the need for renal replacement therapy or a bleeding start or a new infection, and really the difficult part is caring for the patient as a whole. So, what is your, for example, if I may ask, what is your I would say policy in the cases where you keep running ECMO and nothing happens? And I'm certain you experience this too, that like PF ratio, compliance, everything stays stable for days and days and weeks, and sometimes even months, perhaps. What do you do?
well, important point. Because there are also hospitals and centers, they say, well, we do ECMO for 2 weeks, and if it's lasting longer than 2 weeks, we stop it. This is not our policy. Well, we are just having one patient on our ICU, I think is, correct me, 5 months on ECMO. And it's a young man, HIV infection and then pneumonia on his comorbidity. And we have the experience, these are patients who really need a long time, and they're really very difficult to wean from the ECMO situation. And it took us right now about 6 to 8 weeks to wean him from this situation, but right now he is successfully weaned. So there are successes even if you have long-term running ECMO, clear, and, but you're right, and this is an ethical problem where you do run in the most critical situation is in patients who are on a list to lung transplant and who are on ECMO. This might be really critical, and we had from the ethical standpoint, we create critical situation. That's clear. And sometimes we come to the situation that we have to draw back and and withdraw therapy. This is what we also do, and this is sometimes very difficult to do. But for me, what I'm saying is, if you are saying, well, we do have the experience to do this, and if you have the measures to do it, there's no time score where you say, well, from this time on, we skip the therapy and then do a drawback. It's just related to the clinical condition of the patient.
Comment from
How
the
many
floor.
of you work in a center, sorry, and then work in a center where you, I would say, usually do ECMO, where usually means more than 10 times a year? Okay.
So, sorry, Bridge Patel from London. So I'm going to add another layer, ECMO Centre. What are your views on developing a little bit further, particularly with your, Giacomo, your study of the lung safe, saying that actually there's still the mortalities there. Patients with severe ARDS are still on 10 of PEEP, not being prone, of rather than ECMO centres having SRF or severe respiratory failure centres, and on that, if you're going into cardiogenic shock, actually having a shock centre where actually everything is managed through that pathway as opposed to an ECMO pathway.
Yeah. Well, I mean, as you have read, we are calling ourselves not only ECMO Center, we are ARDS Referral Center, and we do the decision after we have, after taking all things into account, do the decision ECMO yes or no. You are completely right. We need, and this is what we are aiming for, and doing the 3 guideline in Germany right now, to have a construction like you have a RDS center with severe RDS, and we have also a hotline, and you have some telecommunication, and then you decide, well, we take them over or not over, and maybe it's possible by just giving recommendation, doing prone, better ventilatory situation, the patient can stay there and being successfully treated, clearly. But if not, then they come to an RDS center, and there the decision is made, ECMO, yes or not. It's much more than only ECMO, clear.
Yes, but yes, I partially agree. I think, well, it's also a matter of economics and stuff. I still think that in severe ARDS, perhaps refractory hypoxemia is, the incidence of refractory hypoxemia is still 1 in 10 cases of severe ARDS, something like that. So I think that every, I would say, middle or middle to large hospital should be able to take care in a very good way of patients with ARDS and providing them the best care. ECMO is something more rare, and for this, for example, in a country like Italy, we have how many? 10 ECMO centers, something like that, for a population of about 60 million. So I think you perhaps need something like that, 1 center in 5 million persons. So in my view, maybe a little bit more, but in my view, you do not need that many ECMO centers. What I would be scared of is the fact that good hospitals that do not provide ECMO feel like, okay, we are not delivering ECMO, so we are not an ARDS center, and if the patient is not out of here, then we don't do prone, we don't do PEEP, we don't do this and that. Because prone, PEEP, I think Those kind of things should be done in every good hospital. And perhaps you should have like a super specialty of hospitals that, of course, you can call for more advanced suggestions, but that then do provide ECMO. So, in a sense, I think I agree that there should be some ARDS center, but I don't think that all severe ARDS patients should go there. And those who do not still should get prone position and this and that.
That's completely clear.
And the other thing I would like to clarify, specifically on the issue of the companies, is this one. Well, first, companies sell because we buy. So if, like, you know, a company might come to you and say, oh, this is very simple, this and that, and blah, blah, blah. But of course, if you know that you shouldn't be doing ECMO, it's very much in our hands. I think this issue of the companies is in part of an excuse to get this material. But there is a catch, which is, and I would like to hear your opinion on that. Low blood flow devices are not necessarily more easier to use than devices with a high blood flow, okay? So it's not the case that a device with a low blood flow, it's easier to use, has less complication, because most likely you would need more anticoagulation, greater risk of clotting of the system. So this is something we should, I think, be careful on. Sorry to...
Well, last comment from the floor. All yours.
The pressure. Thanks very much to both for the talks. I'm actually working in the United Arab Emirates, although I'm from the UK. So just flipping the question a little, because there's been a lot of talk about having the specialist center, central referral, and we're talking about a lot of countries in Europe, as where I trained, where there's a lot more availability. So in other countries who are perhaps newly starting the service, where you have the dilemma of having a team that's very new, not having the same amount of experience, not having the system set up perhaps for retrieval, what would your advice be to people working in that kind of environment that are trying to set up the service, and whether you think it's a place where ECMO should not be an option for that reason, or whether we should just focus on having a centralized service in one place?
Well, when I understand correct, I mean, doing ECMO and this you can learn, and sure you can develop to do. I mean, you can develop into the ability to learn it. And what we do need, for the further future, we need some quality indicators, some criteria which describe a center which describes quality. And if you then develop there and are able to have this technique, that's fine. I mean, that's clearly fine. In a case where it's not that developed, I mean, you come from England, right? Yeah, and it used to be, had one center 7 years ago. But we had from London, they came to us, and we have training programs for them, and we did it with them several times. So go there and learn it. I mean, you can learn it, but still, it's not only ECMO, and I completely say, well, it's the whole puzzle. Use all whole puzzle pieces, and it also means, well, do the right sort of prone positioning. I mean, we could talk a lot about prone positioning, how you do it, and do it right. Find the right PEEP, a really hot topic and important discussion. This also is part of this puzzle, and this is also what you have to learn, but for sure you can learn and you can develop there. That's no, from my perspective, it's no problem.
Yeah, I mean, maybe you're even in a sense in a better spot, because you start from scratch, okay? And perhaps in a situation where you start from scratch, it's a good way to start saying, okay, this is the center where we will do ECMO. So we buy the stuff, we take the people from this center, send them to Germany, to Italy, to London, to wherever, to learn. But this is the center, okay? And I think this is the right way to start, because ECMO, I think, in Europe has been a little bit like the ashes, no? It was getting colder and colder, and then H1N1 came, and all of a sudden there was some gasoline on these ashes, and all the centers started to do ECMO again. But if you start from zero, maybe you can start from just one center and then decide whether you need another one, and you know.
Yes, I would like to thank our speakers, Giacomo and Steffen, for the wonderful presentations and for the vivid discussion.